Good morning, good afternoon, and good evening. It is a pleasure to be here with you, and I hope to give you a brief overview of using IOTA principles to classify ovarian masses and how this can be used to guide management. What is IOTA? Well, the IOTA group was started by Professors Dirk Timmerman, Tom Bourne, Lynn Valentin, and Antonia Testa with the aim of really improving ultrasound-based diagnostics for ovarian masses. In IOTA phase 1, the primary aim of the study was to develop rules and models to preoperatively characterize ovarian pathology and subsequently demonstrate their utility. IOTA phases 2, 3, and 4 involved the temporal and external validation of IOTA principles. And interestingly, IOTA 4 was performed in the hands of examiners with different levels of expertise. External validation is really a crucial step before incorporating any diagnostic test or prediction model into clinical practice. And this establishes whether they work in different patient populations and in different clinical settings. The primary aim of IOTA 5 was to study the long-term behavior of benign classified adnexal masses that were not operated upon and were managed conservatively. First, something simple. This slide really tells you everything you need to know about ultrasound, so pay attention. One of the key factors in describing what we see on ultrasound is pattern recognition. And this is a really simple tool that is used daily and reflects really what we do in daily clinical practice. And the IOTA group used pattern recognition to describe a group of ovarian cysts that are commonly seen and that are instantly recognizable. And these are called the simple descriptors. And really, using simple descriptors alone, we can classify about 45% of masses. And the remaining masses can be classified using the ADNEX model. Simple descriptors describes this group of masses that exhibit these typical features that are quite easy to classify. They are intuitive and really instant diagnoses. And they include simple cysts, dermoid cysts, endometriomas, and advanced cancers. And here's a bit of a video to describe and explain both the 4 benign descriptors and the 2 malignant descriptors. Benign descriptor 1 is a unilocular ground glass cyst in a premenopausal patient, which is really an endometrioma. Benign descriptor 2 is a unilocular, a mixed echogenicity cyst with acoustic shadows in a premenopausal patient, which is classic of a dermoid cyst. Benign descriptor 3 is a unilocular anechoic cyst with regular walls measuring less than 10 centimeters in maximum diameter. And benign descriptor 4 are the remaining unilocular cysts with regular walls that are less than 10 centimeters. The malignant descriptors includes, here if I play the video, malignant descriptor 1 is the ascites, a color score of greater than 3, so 3 or 4 in a postmenopausal patient. And malignant descriptor 2 is any patient over the age of 50 with a CA125 tumor marker of greater than 100. So how many masses can we apply this sort of descriptors to, and how does it perform? Leverka, Ame et al. Published this paper in the White Journal in 2012, and this was data on 3,511 masses, and they found that actually we could apply simple descriptors in 43% of cases. And this had really excellent accuracy across all the descriptors for both benign and malignant masses. What about the remaining masses? Or really all masses? Well, the IOTA group developed and validated a multi-class risk prediction model called the ADNEX model, assessment of different neoplasias in the adnexa, using data from IOTA phases 1 to 3, developed using IOTA phases 1 and 2, and validated on IOTA 3 patients, and really retrained on a whole group of just under 6,000 patients. This polytomous approach to adnexal tumors was really novel because previous models will just tell you if something is benign or malignant, but this really is able to discriminate between benign lesion and the 4 different types of ovarian malignancy. So the benign tumors, as well as the borderline early stage ovarian cancers, stage 2 to 4 cancers, and any secondary metastases to the ovaries and gives you a risk estimate. The ADNEX model contains 3 clinical variables and 6 ultrasound variables: the patient's age, whether the ultrasound scan is being performed in an oncology center, and this variable enables more accurate risk prediction. The CA125, which is really an optional variable, but it does help differentiate between stage 2 and 4 cancer and metastatic disease, and stage 1 versus stage 2 to 4 disease. And then it's got 6 ultrasound variables, including the maximum diameter of the lesion, the maximum diameter of the largest solid part, the presence of more than 10 cyst locules, whether acoustic shadows are present, the number of papillations, and the presence of ascites. These are really straightforward ultrasound variables, and it does not include Doppler, which always seems to be an area of controversy. But the reason this was the case is there was a significant amount of work done at variable selection for ADNEX. And Doppler, from looking through all the IOTA studies, appeared to be a really highly subjective variable and was not found to be really consistent across the IOTA studies, and so was not thought to, and therefore did not perform as well as one would hope. The following videos really demonstrate how to measure these ultrasound variables. So here we're measuring the maximum diameter of the lesion. In this video, you can see us measuring the maximum diameter of the largest solid part. Here is an image where there are more than 10 cyst locules, and you can see that we can count this, and really the answer in the model is whether there are more, yes or no. The next is the presence of a papillary projection, and really a papillary projection is any solid tissue that protrudes into the cyst cavity with a height greater than or equal to 3 millimeters. And really this is solid tissue. And the ADNEX model requires you to input the number of papillary projections if they're more than 3. This can sometimes be difficult, particularly when papillations are like this. They're quite confluent, and this is a serous borderline ovarian tumor. This is a really common appearance of those cysts. And the IOTA group describe that if there is more than a 50% drop in the total height in the middle of the papillation, then these should be counted as 2 separate papillations. But if there is less than a 50% drop from the total height, then this is counted as 1 single papillation. The next variable is the presence of acoustic shadows. And you'll see here, these are classic cysts where you might see them. So this is a fibroma. And on the left, you'll see two dermoid cysts and a cystadenofibroma. And again, the model will ask you the presence of this as a yes or no answer. The ADNEX model also requires you to describe the presence of ascites, and this is defined as the presence of free fluid above the level of the uterine fundus. I really want to demonstrate how we actually use ADNEX in everyday practice. And actually you could use it by downloading the app for a small fee, or using the IOTA website, going online and inputting the variables and getting the results straight. But actually the ADNEX model is now embedded in ultrasound machines, including the Samsung machine. And so you can simultaneously do your ultrasound and apply ADNEX while you're doing the scan. And here is a bit of an example. So you click ADNEX on your machine and you get this. So whilst you're performing your ultrasound, the ADNEX model and the variables are just are on the left or the right of the screen. And you can simultaneously, as I said, input the variables as you scan. Once you've done that, the results will be available to you. The chance of a benignity or malignancy will be there, but also it gives you the various subclassifications of disease. So whether it's a borderline, stage 1, stage 2 to 4, or metastatic tumor. And it gives you the baseline characteristics and the patient-specific characteristics. And this can be saved on your machine. Now, here's just an example of how we can do this in everyday practice. So this is a unilocular cyst with the appearances of low-level echoes and mucinous content. The patient's age was 61. This was an incidental finding. The maximum diameter was 40 5, and I'm going to input that in. There are no real solid parts of the cyst. There's one locule, so it's no more than 10 locules. There's no solid papillations, and there are no acoustic shadows, and there was no ascites. And for this, I didn't have CA125, so I clicked not measured, press calculate, and there you go. The chance of this being benign is 96.3%. And a very low risk of malignancy, and you can see that. And indeed, this was a benign mucinous cystadenoma. This is another mouse, and you can see we're scanning in our unit, and this was the case of a 47-year-old who presented with abdominal pain, and you can see that this is really predominantly solid mass. And so the maximum diameter of the lesion, so I put it in her, I should go back, I put her age as 47, scanning in oncology center, yes. The maximum diameter of the lesion is, you'll see, 57. Because the whole lesion is solid, it's the same as the maximum diameter of the lesion. There are no more than 10 locules, no real papillations, no acoustic shadows. There wasn't ascites, and the CA125 in this case was 606. And I press calculate, and you could see that the chance of malignancy is approximately almost 92%, with a very high chance of a stage 2 to 4 tumor. And indeed, this was a low-grade stage 1 serous papillary ovarian carcinoma. So, does the ADNEX model work? Well, depending on the cutoff of malignancy you use, and this will be decided by each individual unit, its performance will vary. However, choosing a cutoff of 10%, which is what we mostly use and is common practice, you can see that it's got excellent sensitivity and specificity in both the development and validation data set and in the full data set of just under 6,000 cases. Now, your cutoff risk for malignancy will really depend on the healthcare system you work within, the cost of surgery, the surgical risk factors, and also where you're working. It may be that for a tertiary center, you prefer to have a lower false positive rate, and so choose a higher cutoff. The ADNEX model, when compared to other previous models, has excellent performance with an area under receiver operator curve of 0.954. And it's interesting as it shows similar performance to the simple rules, which some of you may be aware of, but actually simple rules can only be applied to 80% of masses, whereas the ADNEX model is much more straightforward to use and can be applied to all masses. This is a meta-analysis of all the external validation studies, which really shows ongoing strong performance in discriminating between benign and malignant lesions using ADNEX. The study by Sayasne in 2016 was performed in the hands of experts and non-experts, and the model still performed very, very well. I wanted to show you that the IOTA group has now worked in collaboration with the American College of Radiology to write a consensus guideline based on IOTA terms and definitions and the ADNEX model to guide management. And this ORAD system, as they've called it, really determines the risk of malignancy and tries to define and guide some management strategies. So you can have ORADS 1, which is a normal ovary, ORADS 2, when you apply the ADNEX model, if the risk of malignancy is less than 1%, it's almost certainly benign, 1 to 10% low risk, 10 to 50% intermediate risk, and 50 to 100% is high risk. And this translates to a system of what we do to the patient and allows us to triage them to the correct management pathway, including whether a conservative approach is an option or whether surgery by a general gynecologist is appropriate, or management really at a high volume specialized cancer center would be best. And this is where classifying the subtype of malignancy using ADNEX is so critical. Because, for example, in a borderline ovarian tumor or an early stage ovarian cancer in a young woman who has not completed her family, it may be possible to offer her fertility sparing options for management of her condition. On the other hand, metastatic ovarian cancers should be managed according to their primary origin and the primary tumor. So this is where this novelty of using ADNEX and this model, the multi-class model, is so important. What about expectant management? Is this safe? Well, when we performed IATA-5 study, this was a multi-center cohort study based on 17 centers with 98 examiners and involved the validation of models to diagnose cancer in patients managed surgically as well as conservatively. Looking at the ADNEX model and its performance in this cohort, it performed very well and was performed best both with and without CA125, but slightly better with CA125. And you can see this is the 2-year interim data that was published in Lancet Oncology in 2019. And it showed that actually there were some really interesting findings, that there was a 16% chance of spontaneous resolution within 2 years and a very low risk of complications. When you are certain that something is benign, the risk of torsion was 0.3% and risk of cyst rupture was very low. The risk of borderline and invasive malignancy was also very low at 0.4 and 0.3%. And therefore, where there is certainty that a cyst is benign, expectant management is a safe management option. The IATA group alongside ESGO, ISWOG and ESGAE have published a consensus statement on the preoperative diagnosis of ovarian tumours. And this was published just recently in 2021, a few months ago. And actually, this suggests that really one of the first things is to perform an ultrasound scan. And you can either have, where there is a non-physiological finding, have an expert assess the ultrasound or apply the IATA ADNEX model. And then you can look at the risk of malignancy and categorize that according to the ORADS classification. And this will lead to the approach, lead you to kind of a management strategy that is appropriate, whether it be conservative, surgery under a general gynecologist, or referral to a specialist oncology center. When referred to an oncology center, again, you can use expert ultrasound, ADNEX with CA125, or of course, in this case, MRI, depending on your unit. And here I just wanted to end on another case example that demonstrates the use of ADNEX and how useful it can be to have this multi-class model to guide your management. So this is a 52-year-old woman who had a regular solid mass on the right ovary that measured about 6 centimeters. There was no acoustic shadows, color score of 3, and she did have ascites. If you used benign descriptors, this would tell you that this was a malignant, this fits with malignant descriptor. Looking at ADNEX, you can apply all the variables here, and you can calculate it with or without CA125. So if we calculate it first without CA125, it would give you a very high risk of malignancy of 95.5%. And the greatest chance is the risk of a stage 2 to 4 ovarian cancer of 75.5%. And this is the patient-specific risk. When we add CA125, which in this case was near normal, it shows that actually it still remains a high risk of malignancy. But interestingly, the risk of a metastatic cancer starts to be higher. It's 34.4%, and it still could be ovarian cancer. And actually, indeed, this was a gastric cancer that had metastasized to the ovary. You can see here the utility of using ADNEX to allow you to think and consider the risk of metastases to the ovary. So in conclusion, using simple descriptors and the ADNEX model allows for accurate prediction of malignancy. ADNEX is really able to estimate the 4 subtypes of malignancy, and it's really simple to use. It's based on very basic clinical and ultrasound variables. And the subjective predictors were really avoided a priori. So we tried to avoid things that would be inconsistent amongst different examiners. It does require a computer or use of the online calculator, or of course you can download the app, which is a small charge, or it's embedded in machines from some manufacturers, including Samsung. So it's very worthwhile if you have the machine to try and use this and see how you go with it. I want to thank all the IATA group who I work so closely with and enjoy such an excellent collaboration in all our studies when we work together. And I want to say thank you very much for the opportunity to speak to you, and I hope you found this talk interesting and useful, and I really look forward to answering any questions from you. Thank you.